Good afternoon, everyone, and welcome to the third information session on this hospital pilot. We're happy to see all of you. We're going to jump right in, even though people are continuing to join. So today, in contrast to the first two sessions, we're going to pass the baton to a couple of hospital systems that have already implemented the Pascal Metrics system. And because we figured, you can hear from us, you can hear from the folks at Pascal, but if we were in your shoes, we would have questions. We would want to be able to direct some questions to those who have actually experienced using the system. So I am really pleased to introduce two people. First, Barb Pelletreau, who is the recently retired, she has another name for herself. It's a great not retirement name. You can say what it is when you introduce her. She's the recently retired Senior Vice President for Patient Safety at CommonSpirit. And she's going to be speaking about the implementation of the Pascal Metrics system when in the Dignity Health system, which is around a 40 hospital West Coast system that was a very early adopter of Pascal Metrics. And then she will be followed by Dr. Peter Shamamian, who is Vice Chairman of Quality Improvement and Performance at Montefiore Medical Center in New York. So I think without further ado, I'm going to turn it over to them. What they are going to do is give you they have some slides. They're going to do a high-level overview of their experiences and how they use the system. Then we're going to open it up to your questions. Without further ado, Barb, let me turn it over to you.
Great. Hey, thank you, Barbara. So pleasure to be here. The word that Barb was looking for retirement, because I'm not sure I retire. There's some of us think we just are never cut out to retire. I'm sure you relate to that. So the word I use is preferment. That just means every day I do what I prefer. And if I'm not having a good day, then I pick the wrong preference and I just change it. So that's the word you were looking for, Barbara. But nevertheless, glad to be here with all of you, because certainly one of the things I prefer to do is to continue the work in patient safety. It's kind of my DNA. It was my passion. It's certainly working at CommonSpirit Health and Dignity, aligning your values and your skills and your expertise with what you do every day almost makes it not a job. So anyway, glad to share with you that. Just a couple things, just to give you a background. And on the next slide, just a little bit about my background and then my disclosures, but just briefly, what I would say in the beginning of my career was I was a nurse, I worked in healthcare, and then as I became more in making and leading change, I kind of ended my career by saying, really, my expertise is large-scale change, getting deliverable, measurable outcomes that make a difference for our patients, and then certainly along my path, I've also worked a lot in employee safety as well. So that's a little bit about my background, certainly working in public health in public agencies when I oversaw employee safety for University of California. And then the last 25 years, I've been in a large system in risk management positions, patient safety, and working with clinical operations for better outcomes. So a couple disclosures, just to make sure everybody knows. I do chair the policy committee of the Collaborative for Accountable Improvement out of the University of Washington. You all might know it as CANDOR, CRP, but they're heavy in that work. Certainly, I'm also a board member with the Health Quality Institute in the state of California, and I support and advisor for 3 different organizations, and one of those is Pascal Metrics. So anyway, my passion continues even though I'm in preferment. So let me just tell you a little bit about kind of set the stage, if you will, from my perspective. So the next slide talks about certainly detection. So, on a very simple note, a lot of our harm in a typical setting is identified by the hacks or what's reported to CMS, or if you're in a state that requires reporting, usually it's like the Never 28 events and those types of things that are picked up. And then also using a voluntary events reporting system. And so working that model, in fact, implementing a voluntary events reporting system over 40 hospitals and 60,000 employees, back in 2007, 2008, we thought that was it. That's the best way to do it and identify harm. And that's kind of the standard. The other ways we learn about harm, and certainly Peter will talk about this, is certainly what comes also through claims. Excuse me, but the world was perfect, and we're trying to prevent harm, knowing that it's the third leading cause of death. Then you want to be able to have a process and certainly supporting technology as well as clinical support to be able to have what I'll call a broader net to identify harm, and more importantly, not just identify it, but then do something with that information and reduce the harm. And then the other goals, just being a patient safety officer and partnering with my friends in quality and risk, is you want as many people involved with this so you have the best outcomes. It can't just be one department or one team or one individual, certainly an organization. So this is the opportunity to bring more into the fold. The other piece I'm going to add on this slide is that I believe that 99.9% of the people in healthcare show up because they want to do a darn good job. If you give them the right information, a path forward, and how to make a difference, how to use the information, they're going to gleam it, get it, and move with it. So that was the part that was pretty exciting to see as we adopted Pascal Metrics across the 40 hospitals at Dignity Health. Ultimately, we merged with Catholic Health Initiatives a few years ago, and then it became CommonSpirit Health. So just the different names you hear as part of that. So you can see where we had on the right side a 26% harm reduction over many years. And then also the looking and using the VPS, or the virtual patient safety, the Pascal approach, if you will, we actually found 10 times more harm than just using an events reporting system. And so that was really enlightening to me, because if you, again, have an organized civil way of sharing the information, and you give people, and those not only at the front line, but leadership, a path forward with what to do with this and how it works with your events reporting system, you can have phenomenal outcomes and make a much better much more of a difference for our patients. So one of the things that we did do is we did do a publication a couple of years ago at the Academy of Health. And how this came about is that I went to what I call my super smart folks in data for the whole company, where they have all the latest bells and whistles, and we gave them all the information on all of the patients that we had, all the patients that came in through the 40 hospitals. And then we took those and had the harm that was identified. And what they showed in using all their analytics and expertise was, I wanted to see, does this work here? Did we make a difference? And what are the savings on that? And what we found, and the study validated, was that we had like $5,500 of direct variable cost per patient that was harmed. So the exciting thing about this for me was we could identify people like immediately. I know in the claim side, which I had a huge partnership, it takes much longer for that claim to come in. It takes much longer for it to get reported. And I just want to tie the last couple slides together and share with you one other observation as a safety officer. So one thing I know is that the front lines are really good about reporting what I call harm at a point in time, meaning we gave the wrong med, we did the wrong site surgery, we left a sponge in. That's what I call harm at a point in time. But a lot of our harm is over time. That patient that deteriorates after coming out of surgery and now is on the med surg unit, and yet when you go back and look clinically what occurred, it actually started in surgery or in the post-op recovery, just as one example. And the same with the perinatal events that have occurred. It's over time, and we're not good at reporting those. We're not good at identifying them because everybody kind of has a piece. The person who's taking care of them now wasn't the person that was taking care of them in surgery. So what I personally really like about this whole approach and identification of harm is that it picks up far more harm, and you can see where those that were harmed cost far more money. So we can not only identify it, but as we know, and we confirm that it's more costly, but now we can do something with the information and make a difference. So one of the things is, how did the front line perceive all of this that was happening? And so again, remember, 99% of the people, at least in my experience, want to do the right thing. And so when you tell them what we're doing, how we're doing it, and how it works, and what we're finding, there was overwhelming support in being able to understand that we're trying to deliver the best care, give the best evidence-based medicine to every single patient. And here's where our opportunities are. So with that, the stories, the trend lines, the things, and are we getting better? What do we need to do? And real-time improvement that all of this can offer to the teams in the units, as well as the hospitals, as well as all of you as a system in the great state of Massachusetts, then you'll be able to use this. And I found the staff was very supportive once they understood what it was. It wasn't a gotcha. It wasn't that we're trying to, identify the bad apples. This was all about trying to get it right for our patients for that. So let's see what leadership thought. So leadership's perceptions are certainly, they always gave a 5-star to analytics. And the part that always tickled me was when we presented this, we would go out to the hospitals, and I always like to hear how people hear information and what they do and how they process it. And the reason is that helps me as a leader know where I need to go to make sure we're incredibly successful with this and making a difference for patients. So one of the things that surprised me was the CFOs really liked this. They could understand it. They could see where the harm was, the variable costs, because it shows the harm. And on the platform, I think most of you have seen that. You're able to see what the estimated costs are for the harm that was identified. And you can slice and dice it into very likely that it was preventable, as well as a level of preventability. So all of that just made it very concrete, if you will, for leadership. And then certainly being able to see the ROI on that. And then the other part that I think people really appreciated about this is that you could answer that question, are we safer? And generally, I know as a leader, they would say, are we safer today than last year, Barb, when you go to board meetings or leadership? And it was always hard to give a definitive answer, because you say, well, what category do you want to look at? And so with that, you can have all of this information in one place and be able to roll it up to a single number to say, yes, we are safer, and here's how our rates are. So it's certainly totally aligned with our high reliability work that was going on with Press Ganey as well. So I was pretty excited about that. So leadership was pretty much thumbs up. So in my world, I looked at what do we expect to have happen at this? And that's the left column. So we expect that we're going to find more harm. So that shouldn't be a surprise to anyone. We should be able to act on this harm that's found. People have access to it. Anybody can go in. If I was in my cardiac unit or med surg when I was nursing, now I'd be able to go in and see what's occurring. Did I know about these? What am I learning? What do we need to do differently? If you're in a unit also that does, certainly at the beginning, some type of safety huddle, if you have a board that you can show the stories that are occurring, If you have rounding with physicians, you're able to use all this information real time to be able to make a difference for patients, as well as for the staff and the physician leadership. So then we also understand what the common causes are, because very nicely in the platform, you're able to identify what contributes to the harm there. So that's very well done and documented. You're able to show an ROI on it. And with that, leadership then is able to embrace it and show the improvement and the direction that we're going in being a better organization for in terms of first do no harm, if you will, and then validating the cost and the direction, the reduction will translate into a program that is sustainable over time. So those are the expectations. So in reality, there is 10 times more harm. I already mentioned that. Now you're going to remember the tenfold. The data supported intervention and improvement. So you can see that if this is our harm and we're making a difference, then that trend line should be able to go down. You see the common causes that are documented. You can break those down. So that's great, because you know that that ties into the evidence-based practices. You can speak to that. You don't just have harm with a number, but you now have the detail on what's attributing to it. Hypoglycemic is a great example of that. And then you're able to reduce by 25% the ROI and be able to validate that as well. So those expectations are met. I think the part that becomes a little more challenging is leadership naturally embracing this. And my learnings were that it made a lot of sense to patient safety. It made a lot of sense to our chief medical officer, made a lot of sense to a few folks to move forward, but to embrace it long term it's really got to be an organization. It's got to be much bigger than patient safety. And so my hat goes off to all of you, because I totally have told this to Barbara. I'm totally envious of your approach in having so many folks involved at so many different organizations, leadership from your claims, your physicians, and you're doing it with the state, Betsy Lehman. Certainly all these key players is certainly far more of a foundation than I had built at Dignity Health for sustaining it. And then being able to validate the cost and the reduction. So that one, certainly using the analytics proved to have that as well. So with that, I mean, one of the saddest things in my preferment, if you will, is that the Dignity Health hospitals, when they merged, unfortunately, if something was not done at every single hospital across CommonSpirit, when they hit financial woes, then it was, they stopped doing the Pascal work and the trigger work. And so that certainly just breaks my heart. But I think looking back, having a huge, a much better foundation that was built beyond patient safety and 1 or 2 leaders is the way to go. So you guys are totally on the right track for that. And then my last slide I would like to talk to is, are we safer? This is like my favorite slide, because I think I've never been able to answer this question until I started working with Pascal and having an amazing platform. And so with that, I'm just going to say the short answer is yes. And then here's all the reasons why. So let me just highlight a couple for you. So what I experienced when we were rolling this out with my team is that we would roll it out, and then 6-8 weeks later, we would go back. There's some rapids you got to go through when people are learning the information and how it's displayed and what to do with it and how does this work with the events reporting system. All those things come up. So I kind of call it's class 3, class 4 rapid that you've got to go through initially, and certainly partnering with Pascal definitely helps getting through the implementation, if you will, with this information. So one of the things is that what I was amazed about is the leaders saw what was going on, and they immediately made changes. They didn't have to wait for reports to come out from quality or safety or their nursing or whoever in the organization produced reports to show how they're doing. It was real time. They could make a difference. And so that to me was definitely incredibly rewarding. The other part is that it really sent a very strong signal to the organization that we are about the right stuff. And I know there's a lot of work going on in, experience for and burnout with those at the bedside in terms of those that deliver care. I just hear it. I saw it when I led all the COVID during the last 3 years I was there. I led all the COVID work across 140 hospitals, and it was just heartbreaking. You guys have heard those stories as well. And to get something that says we want to get this right about safety and about not providing additional harm to our patients, and being able to measure it and know immediately how evidence-based practices are being implemented and adopted, that was just a huge benefit to this whole approach. So with that, then the last part is this is a little altruistic, if you will, but as I get up there and preferment and I start thinking of the next generation and where we need to go, it's certainly an opportunity for ongoing in the next generation of leaders to go beyond just the early adopters. I think I've often been called an early adopter, so I'll just go with that for now. But being an early adopter, it's more than that. And it can be used in organizations of all sizes. And again, it engages leadership up front. It's broadly not just safety leadership, but it can really transform an organization. And it can really go incredibly deep into seeing what's going on at the bedside and how we deliver care. So I'm going to wrap this up with two things. So when I was doing my due diligence on this many years ago to implement this, I think it's been 8 or 9 years, and I talked to an organization that had adopted it, and I was listening to the CNO, and she said to me, Barb, there's many things I get, all these reports. I so related to this. I get the Midas reports. I get all these reports from quality and all this information that comes through. I can go on and, and the CMS and how we're doing with that, although that's years behind. So there's so much information that comes my way. But she goes, if I want to know how we're delivering medicine today, this is my go-to. And that really resonated with me, how timely it was. So I knew if we were doing the right thing today for our patients and where our gaps were in our opportunity. The second thing I will say as I transfer this to transition over to Peter, I will also say that the doctors really appreciated this because they could simply understand this. And it's not, I know when we work on a lot of the quality things, it's what's included, what's not, the exceptions. Sometimes safety and quality gets to be very complicated, but this, they could understand stories. They could understand when the clinical teams from Pascal look and say, we didn't do evidence-based, here looks like the opportunities. It really resonated very simply for the physicians because that was what they were all about as well. So anyway, I'm going to wrap up and I'll look forward to our Q&A, and I'm going to turn it over to you, Peter. So thank you.
Barb, thank you. That was really terrific. And thank you for having me here today. I'd like to say my colleague, Tina Weinstein, who was supposed to be with us today, she's on a well-deserved vacation overseas and won't be able to make it, but she did send her regards and she sent me to fill in the blanks. So I'm speaking to you from the Bronx, New York, from the Montefiore health system. We're a 10 hospital system in the Bronx and Lower Westchester, and also affiliated with the now tuition-free Albert Einstein College of Medicine. The focus of what we're doing right now at Montefiore in using Pascal is in risk management, and it's been initially started in what we call our legacy hospitals in the Bronx. There are 3 hospitals in the Bronx that are really have been affiliated with the medical school and the academic health system for some time. We brought on Pascal, and I can jump right into my slides really because of the issue about trying to find adverse events and trying to find a potential malpractice claim before it was filed. So the elephant in the room for us was adverse events, and we're relying on folks to report the adverse events. And we just realized that voluntary adverse event reporting wasn't getting us where we needed to. over 80% of our claims we didn't know about until the claim was filed. And that lag really hampered our ability to understand and adequately defend a case, to have the memories of the providers that were involved, as we all know. So the elephant in the room is really adverse events. If you take an example of a patient who presents to the emergency department with a surgical complication, the question is, who reports the adverse event, or for us from risk, the potentially compensable event? So the surgeon performs the procedure, sends the patient home. They're not going to report it because they may not even know the patient went back to the emergency room. So then a nurse admits the patient to the emergency room and is trying to figure out what's happening, but they don't really feel it's their role to report that, because they don't know, was this a complication? Is this a known issue with the patient? They don't even maybe know what happened to the patient in the long run. The emergency room physician evaluates the patient and decides on what would happen to that patient, but is, again, trying to consider, is this a known complication? Was this an error? Is it potentially compensable? How would they know? And then finally, the critical care who responds to the code, and I put that in there, just as a, put a little emphasis on this. They're just responding to the code, they resuscitate the patient and bring the patient up to the ICU. But we never hear about this case until the claim is then filed. So how can we hear about this soon? Identifying the adverse event or the potential compensable event in near real time allows us to reconstruct the event. So careful chart reviews. And what we're doing now, and I'll just speak about this a little bit, is interviewing the providers involved with the case. So from a risk perspective, that usually happens by defense counsel some years later after the event. Now that we're finding out about events in near real time, we can actually look at the record and see who was involved, look at the notes, see who wrote the notes, look at the operative report, and see if it was dictated by a resident or a fellow. Does it really make sense with what happened to the patient? Was it authenticated and reviewed by the attending? Was the consult note reviewed by the attending? What did the radiologist say? Was that reading then adequately or appropriately transferred into the chart, and was it acted on in real time? So there's so much that happens in the care of a patient that never really makes it into the medical record. A patient's on a clinical trial, for some reason it wasn't mentioned, and the consent form for the clinical trial was not brought into the medical record. We find out about that, and that helps us understand what happens with the case. And all of this information is now taken, and we actually use Pascal to communicate with risk management within the platform, within the PSO. So it makes it much more efficient for us in this. And again, we collect data from Pascal and the interviews. So we're able to now reflect on the interviews that we're doing, the appropriateness of those interviews, et cetera. And then we can make a plan. And this is another key point. So hearing about the event in the moment, in near real time, allows us to mitigate, allows us to reach out to clinical leaders, operational leaders, physicians, et cetera, to say, this is what's happening to this patient. We're concerned about it. Is there something that we can do? And also allows us to understand how we could potentially defend the case if that should come up, and who we don't want talking in a deposition, et cetera. I mean, it gives you a huge amount of information. We've really learned from this. This is something that we've not been able to do before, because again, the length of time is so great. So this is sort of really kind of preliminary data, but if I can just take you through this a little bit, the upper arrow, and this is not to scale, is what we're experienced now with the adverse event review process with Pascal. And this is just from January and February of this year. We get the average adverse event from Pascal. It takes about a little over a day for the notification of the adverse event to go to risk management and determine if it's a potentially compensable event. And then we go through our interviews, and that takes about a week, and we finalize that interview. So from the time of the event, it takes just over a week, about 8.5 days for us to get an idea about that case, about whether we think it's a potentially compensable event, and how we should monitor that case, or should we just send it right over to our carrier and their claims department. I'll say you see the initials in there finalized by HRA review. That's our malpractice carrier. So we actually do this in collaboration with the malpractice investigators with our carrier, and they do have access to Pascal and the notes, et cetera, we put in Pascal. Contrast that with how we used to do this for adverse event reviews for voluntary adverse event reporting, and we looked at all calendar year 2022. So from the adverse event date until there was notification to risk management and to come up with a potential compensable event determination, it was about a month and a half. And then it took another 6 months to actually finalize that review. So it was almost 8 months from the time of an event, from a risk perspective, to sort of decide what potentially would happen with that case. Gave us really no time to reflect on it, gave us no time to intervene on the case. And of course, when you're 7 months out, there's really not much you can do with that. And likely if you're going to get a claim, that will come in around that time. What happens with Pascal is the adverse event document that is created allows our risk managers to target specific adverse events based on the filtering that they can do. So we've set up filters at the severity, the type of adverse events. In specific departments will have different filters for surgery, for OB, for nursing, and it greatly improves the efficiency of the cases that they're looking at. So they're able to look at a more significant number of cases, so smaller number of cases, but the significant ones. And I'll just show you a little bit about how this has really worked out. So we've increased the efficiency, review more relevant adverse events. So in our first couple of months of this year, 56% of about 300 adverse events that were identified by Pascal were PCs. So in other words, there's a really significant filtering of these events so that they're able to look in depth at 300 cases and realize about 150 of those were potentially compensable events. So we put a lot of time into those. In contrast, in 2022, with our MIDAS adverse event reporting system, the risk managers looked at 7,000 cases, and only 4% of them they felt were PCs or required any additional investigation. So it took a lot of work to get very few. Where now we're able to look at fewer cases, but in more in depth, and really helps us. So the more PCs are identified, it increases the opportunity to mitigate harm, and of course, the financial risks of the organization. So near real-time notification of those events promotes risk mitigation. I'll talk about some lessons learned, and this is what we've learned from the Pascal platform, and also our approach, the way we manage on our workflows now in risk management that have changed using this. So the idea that malpractice arises from an infrequent adverse event, right? So it's, that happens so rarely, we get sued so rarely on that. It's, the claim came in, but there's really not much we can do about that. What we've learned now, we need to capture 100% of adverse events, because we see many, many more malpractice-like cases that are infrequent. So these are surgical complications, a patient discharged and returns to the emergency room, glucose management issues, things that we thought were really rare and almost one-off from a malpractice perspective. We're seeing them much more frequently as adverse events. So now we can actually convince the clinical teams we just never knew about them, but now we know about them 100% of the time when they happen, because that's what Pascal tells us. So there's also a cluster of complications, and we sometimes refer to as a parade of horrors. So the adverse events don't occur in isolation. So identifying the first event can help direct and mitigate efforts to prevent the subsequent event. So it's a patient with a complication that ends up in the ICU that's now at high risk for a pressure injury, for sepsis, for pulmonary failure, et cetera. We see that these things happen, and it's not just the isolated adverse event. And this is what happens in malpractice. It just gets worse and worse and worse. So removing the emotional barriers to adverse event reporting. Although encouraged, many providers don't know when to report to risk management. And that's sort of what the concept of the elephant was, is everybody sort of touching a different piece of this case, a different piece of the cluster of complications, but who's going to report? This also helps us get away from known complications, because those can be adverse events and potentially compensable events. So the idea of, I'm a surgeon by training, and an anastomotic leak. We try to sew the intestine together. It doesn't heal. It falls apart. That's a known complication of the procedure. But knowing about every one of these actually allows us to look into them much deeper around the events surrounding that, so that we can better focus on what happened in that case and decide what else can we learn from it, make sure all the I's are dotted and T's are crossed on the chart, so that we can try to mitigate any risk. The other thing that we've noticed is when approached, the providers are really eager to share their insights in a non-judgmental, protected environment. So before we were asking them to report issues that came up, now we're reaching out to them and saying, I noticed that you were taking care of this patient, and you gave him this medication and created these problems with this. And they'll say, how did you know that? And they're a little bit surprised sometimes, but when we tell them about Pascal and how we get notified, they say, wow, thank you so much for reaching out to me. I really want to talk to you about this. And it really creates a safe space and a real eagerness for the physicians to speak to us, the nurses to speak to us. We had a great conversation with a PA just before I got into this call, learned a whole lot, because they know that we're there to protect them. We know that that's the purpose of the phone call and the interview. So we have a path towards real-time risk mitigation. As I said, there's opportunities for clinical and administrative mitigation while the patient is in the hospital. So do we need to get other extra specialists there? Do we need to notify somebody that their patient is in the hospital on a different service than they knew about? And is there something that we can do to help the patient and the family now that this has happened? So is there something from an administrative perspective we can do? And we close the documentation gap. Again, were the notes written and complete? Are there any errors in the notes that we need to do? And we saw somebody write a note the other day. Their patient had a high-grade stenosis of the carotid artery. They only wrote 50%. For some reason, they wrote the wrong number. They were able to go back and fix that. And we're learning for providers on the care that delivers, so we can defend the defensible. Right? This is really key. What happened? We kind of know what happened in the chart, but what were you thinking and how did you approach that? And we get that down so we can note it should a claim come up in the future. And I think that's it. Thank you.
Thank you very much to both of you. So we're going to open this up to your questions. I see a couple already in the chat, so feel free to either add more questions there or just use the hand raising feature on Zoom, and we'll get you in that order. I just have a quick preliminary question, just building off of Peter's presentation. So, as you can tell, I mean, the Pascal Metrics system was really developed initially for a patient safety improvement, from a patient safety improvement standpoint. Obviously, Montefiore is an example of a hospital that has sort of gone through the door of risk management. But when we were talking earlier, Peter, you had mentioned that even though that's been the case, there has been this demand. So once the clinical leaders in various units have come to realize that these data exist, that the system exists, there's been actually a demand from the patient safety folks. Can you just address that a little bit?
Sure. So, as I mentioned, we're going back to the care providers to talk to them about cases, and we've experienced now when we explain to them, what we have, that we often get the responses, I want that, I want access to that. So very early on, we were partnering with obstetrics, and they use this now to screen out adverse events on the OB service. Nursing is using this to identify pressure injuries and falls. It takes the burden of the nurses reporting back to the nursing quality team because it's picked up through Pascal. I know that we can run a report in Epic, but it's not in near real time, right? And it takes some time to get to. So now they can do things to help understand and mitigate a fall or pressure injury. And it takes the burden of reporting off of the frontline nurses. They can spend time with caring for the patient and appropriate documentation. So our weekly Pascal report from risk now goes to patient safety as a document within the protected environment. So patient safety can now move off of that. And I'll just say that any event that comes in that's reported or found in a different way, we add into Pascal. So it's rare, but sometimes there's something that comes up that we'll put in. So patient safety is now using it at a work list. They're using the platform for their serious safety events and never events, and that's picked up. The emergency department, general surgery, orthopedic surgery, and again, I sit over the sort of quality in the Department of Surgery and the Department of Cardiothoracic and Vascular Surgery. So obviously, I do pick up the cases there. So it's really growing, and it's sort of from a grassroots, bottom up sense of folks saying, wait a minute, how did you know about that? I would like that. I want access to that.
Great, thanks so much. In the chat, John, you had the first question, and I see that Barb responded. Does that basically answer your question about the impact on revenue? We'll come back to.
Okay.
Oh, there it is. Okay.
Yeah, I think that does. Thank you.
Okay.
Thank you, Barb.
Great. And then Mary Ann's question from results and learnings at your hospitals, what contributed to the successful or unsuccessful implementation efforts, and how is the safety engagement embedded into the hospital's strategy for sustainability? Barb, why don't you?
I'll jump in first. And so first of all, I'll tell you what makes it successful. I kind of looked at the what I'd call the fabulous four in a hospital, and I'd call it the team: the CMO, the CNO, the quality lead, and the patient safety officer. If those four were on the same page for how to manage the process of the implementation, the information, how does all this flow, how does all this work together? If those four individuals were coordinated and in alignment, if you will, it went really smoothly in the organization. And of course, people want to always say the hospital president, but once you get to that point and you've implemented it, all the folks have signed off on it. But the key I think, to success is that those four are in total alignment on it. And, certainly the identification of events and being able to talk through them when you do the root cause analysis and having candor and how are we going to do all that. It took what I call the fabulous four. So I'll start with that. What made it successful? I guess what makes it unsuccessful is one, if the fabulous four aren't on the same page, so to speak, but more so if you have new players that come in, making sure that they get on board and they're trained and they're up to speed. Because I think if you go back to one of my slides, you can see where the trend line goes down and then it pops up. And at the end, and occasionally people pick up on that. So like, wait, it popped up. What are you doing? Or what was going on. And it was very easy with the Pascal Metrics or the platform to be able to dive down and say, where is this happening? What trigger is it? Where, or triggers? And then you can go down deep and find out, gosh, we had a new whatever that came on and they didn't know how we did this evidence-based and how we managed hypoglycemic, events or whatever it was. And you could then bring them up to speed. So it's not only, identifying it and fixing it, but it's also being ongoing monitoring it to see where the spikes are. And I think, Peter, I said hypoglycemia, and I think that's a great example of how an organization can take the platform and between, say, pharmacy and lab, and they say, wait, we want to get to zero hypoglycemic events. How can we do this with using this? And they were able to do it. Many hospitals took hypoglycemic events down to almost just such a rare event that occurred. And so anyway, with that, I think that's kind of a broad, solid answer to your question. And then there's how was the safety engagement embedded in your hospital hospital strategy. So certainly, you know, when you do this work, you find out you have a lot more friends than you originally think of. And so I've certainly learned that communication and strategy needs to know what's going on. And they usually have wrapped up the safety into a higher level of wording, if you will, for the public or the strategic report, but they're not going to list everything. That's not the way they work. They're going to give a global that says, you know, we're about the highest quality and safest care, and however they strategically put it together in their plan going forward, but having them understand what you do, certainly in your communications and your strategy team, and certainly also with the financial CFOs, all make them just stronger players for supporting it in the clinical front line. So it's not just clinical, if you will. I'll turn it to Peter if you have anything to add.
Yeah, I think one of the parts about implementation, and I want to emphasize that we did this in collaboration with our malpractice carrier, and they sort of, you know, we had an agreed understanding of the issue about trying to get events reported. And for a long time, we had discussions with them about, you know, send us all your events. And I said, well, how would you like them? And by mail, you know, homing pigeon? We didn't have a platform to share it. And a format. Now we do. We have a platform and a format, so it makes it seamless. It's very easy to do. You know, using the Pascal platform, it's easy for us to upload documents and to communicate with each other. So it works really well, and I think that helped because it solved a couple of problems at once, both with risk management and communication with our carrier. I think that you know, the slow sort of tap on the shoulder to people to say something happened here has been very, very much appreciated. I will say, David Stockwell mentioned to me that early on, you're not going to believe the hypoglycemic events, and he's so right. It's something we are completely blind to that. And it's actually opened up the door, I think, to have an impact from a safety perspective. And I think that's brought a number of people in. I think that it's also not a kind of big brother program. People begin to, our colleagues begin to realize that we're not watching over them, we're watching out for them. You know, the idea of volunteer adverse event reporting is the sense that there should be psychological safety, but you know, when there's an adverse event, folks are nervous. And now we can go to them and say, you know, we're here to help and to support you. And how can we do that? I think they feel that, you know, rather than the sense of either they have to report something on their own or somebody's reported that. So a lot of our conversations really center around that. You know, we're here to help, and we're on your side. Sometimes the meetings can start off a little bit tense, but I think they do relax after a while because again, it's really meant to help. And I think this is added to the sense of a safety environment now in our hospital, because we're getting to see more, and it allows us to actually look at it. We're not as far down the road as Barb is from a safety perspective to know those outcomes, but at least we know what's happening now.
Great. Paula.
Thanks. Yeah, it seems like clearly a really powerful tool, and in itself, if you've been able to engage physicians who coming forward proactively and feeling like they have information and working on improvement, that's a really powerful demonstration of effective engagement. So I'm just interested in terms of how to make sure there isn't sort of some inadvertent downside from the way that the tool is used, not compared to what you're talking about with only, you know, frontline reporting and then a safety department that does the analysis, but in a context where you're trying to have frontline clinicians and staff be part of seeing and solving problems and looking for the accident waiting to happen and looking for harm and thinking about the process and how the process could be improved. So I'm curious if, Barbara, probably you first, but Peter, you as well, if you have comments about because I'm interested in, how do you not have people say, oh, good, I don't need to report. I don't need to look for harm. I wait for, the risk and safety people to show up and ask me questions. How do you still have them engaged in thinking that they're responsible for improving safety and seeing and solving problems? And then related to that is also, is there a way to ask them to think about harm that might not be visible with the Pascal triggers? There clearly are a huge number of triggers, but I suspect that there still might be things that don't immediately come from the Pascal triggers, but maybe that isn't true. Anyway, interested in reactions to both of those questions to really maximize the impact on safety.
Okay, break this down. Your first question about the front line, and they have the events reporting system, voluntary events reporting system, and now you've got this other tool, which clearly they overlap, but they complement each other. So explaining that up front and through your communications process and when you onboard this, is that clearly you want them to keep reporting into the events reporting system. But however, you get down the road and you start finding out that all these falls are also being picked up in the medical record or the pressure ulcers. And so what we were able to do over a period of time was the hospitals were able to say, you no longer need to report the pressure ulcer. We already are picking that up. If you just make sure you chart it here, here, and here, we're good. But so that's what we were able to do with quite a few of them. If we when we saw that the triggers were picking them up and they were really solid. Everybody loves to hear they get to stop doing something. Now there were still a few that says, oh no, I just want to cover myself and we're going to report it. No harm, no foul. If you want to report it, no problem. But you just need to know we're picking it up over here as well. So that was one, and anywhere where we can reduce work of the frontline folks, all for it. So that was the thinking at the hospitals, and certainly supported from us in the corporate, the system office. Your other question, I'm sorry, remind me.
About types of harm that might not be identified by the triggers. And frankly, that's related to the first question too. You have the chance maybe to ask the clinicians and the staff to focus on things that don't get reported through the EHR. But I'd be curious of how do you, is there any explicit thinking about what wouldn't come out of the triggers?
Yes. Okay. So I will just say also one of the great things that happened, and I'm just so envious of Peter, because certainly when you do safety right, you should not only have safer outcomes, but you should see a reduction in your HPL liability costs. So Peter is totally in the team, is totally on the right track in aligning all of that. We were just starting to do that before I went into preferment, but that is absolutely the best and the sweetest spot. So the feedback loop would be, and Peter certainly, I'm sure, will speak to this, is when a claim comes in or something happens and it's not there, but it's identified as harm, then to be able to share that with your partners to see what kind of triggers could be built for that. And I know we did a lot of work with David Stockwell, and I see Suzanne Miller, their CIO, on the call, that were very good about when we could identify something, and then it's like, what are we going to do to help that be a trigger so that we can pick it up earlier before on that. But let me turn it over to Peter, because that's a great question for Peter and his team and the work they're doing.
Yeah, thank you. One of the things we're going to continue to track is how many reports come through our voluntary adverse event reporting system. There's been a sharp increase over the years of events reported, and what we want to hear is our staff speaking up about safety conditions. I think, in an interesting way, and this is not scientific and it's just anecdote, people are sending me emails about adverse events that happen now. Did you know about this? Did you pick this up? So it's kind of interesting, and because my role in this is I'm the clinical advisor to risk management loss prevention, and I'm involved in a lot of the interviews with the staff. I look at most, if not all, of the potentially compensable events that come through to support our risk managers. So folks know me as the chief quality officer for a long time, but it's kind of interesting that people are reaching out to me and saying, do you know about this? And I think as Barb mentioned, when you're going to your colleagues with a message of, I learned this and I want to understand it because we want to help you. I think that is a very positive message. And I think that, we never, and we will never suggest that we can remove voluntary adverse event reporting, or should we? We want to. We want people to continue to report, but we can also.
Well, Peter, I'm sorry, if I could just ask, I didn't mean to replace things that get reported now. I guess I'm thinking about, is there an effort to think about, someone is discharged and goes to a different hospital, or gets support in a post-acute setting but doesn't come to the hospital.
Yeah.
Is there a way to have people think about, are we capturing all harm? Is there harm that we're not capturing? We really need even to invite patients and families to bring that to us, or invite clinicians and staff to bring that to us. What are the things that we would otherwise miss, I guess, is my question.
Yeah, I wanted to, there are definitely events that at present time won't be captured, but I think, as Barb mentioned, Pascal is a real collaborator with us, and we learn a lot from them. And I think that I'm not going to speak for them, but I think that if there is something that we think is a trigger that can be captured, it would be. I think they would create something for that. They clearly, it's built on itself over time. So I'll let the Pascal folks let you know how that would develop.
Okay, so we are right at 2:00, and I know a couple of people have already had to leave because I know people are tightly scheduled, so I don't want to go too far over. There are a couple. It looks like, Barb, thank you for answering Ivy's question about the pharmacists, and Marianne, you had a question about safety culture, which is probably a longer discussion, but just in a nutshell, if Barb and Peter, you could react to sort of what if, how well developed does a hospital's safety culture have to be to be successful with this?
Well, that's an interesting question, because I would get calls nationally, or when I was at conferences, that said, should we do HRO or should we do Pascal first? What do we do? Well, eventually it all needs to be put in place. Do we do Candor? How does this all work? Well, they're all important parts of the safety and making sure we deliver the best care to every single patient. But what I will say on culture, if you don't have a safety culture, this is going to give you one. Because again, my assumption and my experience has been 99% of the people want to do what's right. And if you're always trying to say, we want a different culture, we want a better culture, that's really hard. We do surveys, we're required to do surveys to be in Leapfrog and all this. And we spend all these time on these questions, and they move up 0.2, and we're all excited. Next year they go down 0.4. It's kind of crazy making at some point. It's a barometer, but this is hardcore. And I find that people can't argue with these stories because they're clinical. And you could say, this is what happened. Here's what we know. Here's how this happened. And yes, it's at our facility. And yes, we can do better. And here's what we're doing. And here's our evidence-based practice that's been approved by the OB committee, the surgical, blah, 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 all the key players, and the pharmacist, the medication safety pharmacist, as somebody asked in the question. So I just find that this approach takes us to the core of what we do and what we want to do well, and when we're not doing it. And it just gives you, I always say, the story on a silver platter. With the clinical, they pull it together. It's in one place. If you don't believe it, we can all go to the medical record and see what's in there. You might find that you're pretty shocked at how bad charting is. You might find in these clinical records that people no longer look for information. So you might find a lot of things that are not unintentional, if you will, that can really help and make for it. But I like this because it will drive a safer culture, regardless of where you're starting from.
I think the platform brings out transparency. which is extremely important. That will drive a safety culture, because I agree with Barb. Pretty much everybody wants to do the right thing. And when things aren't going right, they want the support of leaders in the hospital to come there. So just knowing that something went wrong, but how are we going to fix this? How are we going to prevent this from happening again? Did somebody hear me? I think that will come out. That will definitely come out.
All right. Well, with that, I just want to thank Barb and Peter. This has been extraordinary, and it's just, and I'm sure everyone has found just hearing from you has been just really meaningful. I also want to let you all go because we're a little bit over, but just want to mention that then our next session, the final session is we're skipping a week, so it'll be Thursday, May 23rd at 11 o'clock, so different time, slightly different day, and that's the one where we'll be talking more in greater detail about the application process to become a pilot hospital, and the contracting and the data use agreements and all of that nitty gritty. But in the meantime, and we're going to send you an email early next week about this. We really think probably the best next step for any of you who have a serious interest in pursuing this, becoming a pilot hospital, the next step will be to schedule a one-on-one conversation with the Pascal Metrics team, and we'll participate. And so, because you're all coming from different places, you have different questions, and the Pascal is more than willing to have those individualized conversations. So more about that by email early next week. And and if you want to go ahead with that, you can shoot us an email in the interim and say, yes, please sign me up, and we'll just start the scheduling process. But we'll give you a little more detail about who from your end should participate in these, plan to participate in these conversations, just so we make sure we have everyone there who needs to be there. So with that, I just want to thank everyone. Also to thank Drew Ladner and David Stockwell, who have been sitting here listening very quietly, and and all of you for turning up on this Friday afternoon and staying over. But just thank you, and reach out with any questions, and we'll be in touch next week.